Okay. Well, I think you have heard it's a variety of people coming from different areas of the world, but also from different disease background. And I think that that's really what we are looking for also within OMERACT. I'm just muting you, Tom, because I think there's some noise on the line. What are we going to discuss today? I think the objective is really to provide a general introduction into OMERACT. And then specifically, we will tell a little bit about the history, what are the main objectives of OMERACT, and then there is something that we call the spirit of OMERACT, some specific characteristics of the organization. We will introduce to you the so-called OMERACT framework for concepts and domains. We will talk a lot about domains, but we will explain them in a minute. We will introduce how OMERACT develop core outcome sets. And then finally, we will also introduce your role as a patient research partner in the development of core outcome sets, and specifically also how you can contribute to the work of an OMERACT working group. I think it's good to emphasize at the start of the meeting that there's a lot of work and research going on in the working groups, and actually that is the heart of OMERACT. There are more than 40 working groups that are all looking at core outcome sets. And then there is every second year a meeting where people can meet, discuss, but also where there is some decision making. It's good to emphasize now that participation in this webinar does not ensure or imply that people can participate in these meetings. So that really depends on whether the topic of a working group is on the agenda, and then every working group is allowed to send one nominee to the meeting. So there is only a small number of patients that will attend the meeting. So now I would like to hand over to Pam, who will introduce and tell a little bit more about the history of OMERACT.
Hello, everybody. It's nice that you're on the call, whether it's morning, afternoon, or evening, wherever you are. So OMERACT was initially set up, and it stood for Outcome Measures in Rheumatoid Arthritis Clinical Trials. If you could have the next slide. It was started in 1992 by initially 5 people set it up, and they brought together quite a large, sort of about 90, I think, of researchers and clinicians from around the world. The aim at that meeting was to get consensus about what are called endpoints for rheumatoid arthritis clinical trials. So that was their specific aim at that time. But over the coming years, it has developed its own sort of ethos. Its credibility is renowned throughout the world. Even though it's a relatively small biannual meeting, the work that goes on every day between the 2 years is enormous, and it's taken very seriously. So a lady called, there's a researcher called Caroline Fleury developed a research looking at what made OMERACT different. And the research paper, which is on the OMERACT website, or the conclusions are on the OMERACT website, was called The Spirit of OMERACT. Out of that, she came across 8 C's that define the spirit of OMERACT. I'll give you a flavour of some of them. It's consensus, it's about communication, about collaboration, about concrete outcomes and continuous learning. So basically it's data driven. OMERACT is all about getting the evidence, and you get the evidence by repeating the process until you achieve consensus. It's inclusive in that there are lots of people involved. Everybody has equal status. Because you've got a professor or a statistician or a patient, they're all equal and they all have an equal voice. It's interactive and non-commercial. So at OMERACT, unlike some of the bigger conferences and meetings, there is some pharma, but it's not about commerce, it's about research. So it is a multi-stakeholder approach with doctors, patients, all sorts of academic researchers, fellows who are the new researchers coming up through the ranks, who are supported by the more experienced researchers, and from industry, just a few pharmaceutical companies who send some of their researchers along. Thank you, Martin. So an example of an OMERACT core outcome set, the very first one that was agreed was in 1992 at that Maastricht conference in the Netherlands. And the attendants there looked at which domains or which areas of health would you want to make sure are measured in every single rheumatoid arthritis clinical trial. And they agreed on these 8 items, pain as a domain, right through to x-rays. Those 8 items then formed a core set, a core outcome set to be measured in every trial looking anything to do with rheumatoid arthritis. Thank you, Martin. So that was the core set for many, many years, and it was a very, it was kind of like a turning point for the way treatments were measured. But in the year 2000 at an OMERACT conference, the participants there, which didn't include patients, were trying to define what was a minimal clinically important change in response to treatment. And they decided at the end, during the voting, that question could only be answered with the input of patients, because to us, what's minimally important difference might be different to what a doctor might think. So the following OMERACT, they invited 11 patients and they reviewed that rheumatoid arthritis core set that was designed in 1992. And at that meeting, the patients, all the patients and a couple of the researchers are around this table, they raised the fact that for them with rheumatoid arthritis, fatigue was an often overlooked domain. It was really important to them, it had a big effect on their life, and it was often dismissed. So the researchers went away, one group in particular carried out a lot of focus groups, etc. And then 2 years later, they came back to the following OMERACT meeting and said, yes, we have shown that fatigue is a hugely overlooked area. Some of the work that was done by a lady from Ireland, her study actually put fatigue in, for many people above pain at times. And then that from the year 2002, for quite a few years later, we then were able to get an OMERACT, so an outcome measure called the Bristol Rheumatoid Arthritis Fatigue Scale, which could actually measure RA fatigue. Until then, we didn't have it. So the next slide, please. So following that, it meant that we had a way of measuring fatigue, and it was agreed at other meetings, particularly within the EULAR research area, that fatigue should be measured as part of that initial core set that was developed in 1992. So what is a core outcome set? Well, it's a minimum number of important domains, as we've said, pain, x-rays, etc. Other things like inflammation and fatigue. So you've got that minimum set, but then you also need to know how to measure each of those domains, each of those areas of health. So you need a corresponding number of outcome measures. Outcome measures, we talk about instruments and questionnaires. Instruments might be, blood tests, x-rays, questionnaires, such as you've probably all filled in the health assessment questionnaire at the hospital. You tick a box and it says how your arthritis is at the moment. Another instrument is when you get your joints squeezed at the hospital to see how they're doing, whether they're all puffy or inflamed. Others might look at whether you've got sort of white spots, or there's all sorts of ways of measuring, and they're called instruments and questionnaires. They're the outcome measures. Thank you, Martin. So you have your minimum number of agreed domains and corresponding, you have the ways to measure those domains. I hope that's making sense so far. So OMERACT, the main measures are to develop and agree on those core outcome sets so that they can be used throughout the world. To advance the methodology of clinical trials, in particular the selection and development and validation of measurement instruments, and that's really vital. Somebody could just draw up a questionnaire and say, well, there you are, I'm going to see how well this particular treatment is working. So you might have a physiotherapy treatment, and they just fill out a quick questionnaire, but it hasn't been developed in a methodical way, not with good science, and not validated by other peer groups around the world. So OMERACT is making sure that the outcome measures are developed in a specific way, passing a number of tests, and that makes the research more robust and of better quality than many others. It also includes the input at all points of patients. So all outcome measures developed away from sort of OMERACT, but with the OMERACT kind of quality flag, have patient input throughout and not just as a tokenistic thing. The other thing that happens at OMERACT is that we develop a research agenda. That's okay, Martin, continue. We develop a research agenda for future studies, because not everything can be measured because we don't have an appropriate measure. So when fatigue was set up, we didn't have a measure that could look at that adequately. So that becomes part of a research agenda for future studies. Thank you, Martin.
Are there any questions so far? So if not, then I propose that we continue and say a little bit more about core outcome sets, how they are developed, but first of all, why they are so important. So why should we be worried about this? I think it's important to notice that we have to realize that clinical evidence has a huge role when it comes to market authorization for new drugs and also for the development of treatment guidelines. So we want that the evidence that is used for allowing drugs to enter the market, and when physicians and patients develop guidelines, that they are based on the best possible evidence. And this evidence comes from clinical trials. And therefore, we want that these clinical trials really reflects the outcomes and findings and results that are important for patients, and not only the endpoints that are important for physicians and other stakeholders. So I think that is an important reason why we need core outcome sets. And having a core outcome sets also enables us to compare outcomes from different studies. So that means that if 2 or 3 different companies or researchers study the same drug, we want that they use and measure the same outcomes. And if they use the same instruments, then we can compare the outcomes from one to another. And this is, it sounds like very common sense to do this, but in many diseases, this is not the case. And there are many different instruments and many researchers use different outcomes and they report different outcomes. So there is a lot of space to improve the standardization of measuring outcomes. And then there is a second benefit from having this standardized set, and that is that also researchers are forced to report on all the domains that are included in a core set. So that reduces the bias of researchers that only report the domains that they see are improving in their trial and leaving out the domains that are not so doing well. So they are forced that if the core set has 7 or 8 domains, you need to provide the evidence and outcomes of all these 7 or 8 domains, independently whether they are good performing or not. So, and then finally, and that's also what we have learned, researchers want to get guidance, what they should measure, and standardized core sets offer them this guidance to do clinical trials. What helps very much is that also the regulators, like the FDA in the United States and EMA in Europe, they are very supportive of the use of core outcome sets. Representatives of these organizations are also critically following what OMERACT is doing. They attend our meetings, and if they think that a core set is developed in the right way and in a robust way, they will make it mandatory for companies to provide and use these core outcome sets and provide all the data that is required for authorization. So now let's have a look at the way that OMERACT develop a core outcome set. And we do this in 2 steps. A core outcome set actually contains 2 separate sets. The first one is a core domain set, and that reflects what is important. So it says what domains have all stakeholders prioritized that should be measured in every clinical trial. And only if you know what is important, you can start thinking about how to measure these domains. And then you look at instruments. And OMERACT is one of the very, very few organizations that makes this distinction, first looking at the what, before you are going to look at the instruments. So the what is clearly leading in this. For today, we will focus on how we develop a core domain set. And although the development of both sets is slightly different, it will give you a idea how robust the method of OMERACT is to develop such a set. If we develop a core domain set, what is the expected result at the end? Well, for every clinical trial for which we develop a core set, we develop and we call it the OMERACT onion. And the onion is the circle with 3 different layers. If we start in this figure looking at the smallest circle, then we call that the inner circle, and that's the actual core set of domains that are mandatory to measure and report in every clinical trial. And since the last meeting, 2018, we have made a small distinction in domains that should be measured mandatory always, and some domains that are mandatory to measure in specific circumstances. And that could be, for instance, measuring a particular symptom for people who belong to the patient group, but only because they belong to a particular subgroup of patients with that symptom. So not all people have this is just an example, with ankylosing spondylitis, have uveitis, but only in the subgroup who are affected by uveitis, it's mandatory in a clinical trial to test and measure the impact on that domain. So that's what we call a mandatory domain in specific circumstances. Then, if you look at the middle circle, that contains all the domains that are also important, but they are not mandatory to measure. So they are not core. They are summed up in the middle circle of the OMERACT onion. And then we have the outer circle, where all the domains are mentioned for items that we do not have enough information. So we don't know the severity, or we don't have an instrument to measure it. So these are all the topics that need further research. And that's an important outcome and reason for OMERACT also to come together. This is a very busy slide, but in a way it summarizes all the types of domains that we need to consider when we develop a core domain set. And it has different levels, and if we start at the upper level, it distinguishes between domains that belong to the concept of pathophysiology and domains that belong to the category of impact. So you have symptoms and you have impact. And we will describe and give some examples for each of them. If we start with the pathophysiology, you have to think about all the manifestations and abnormalities that are characteristics for the condition. And examples are, for instance, pain, fatigue, particular organ involvement, function of the joints, but also something like structural damage. So these could be related to erosions. And then, if these are the pathophysiologic manifestations, and then we look at the impact of the condition. And then there are three different categories. The first one is life impact. What is the impact of the condition on everyday life of the people who are affected by the condition? And then you have to think about the impact of pain, of fatigue, and something like anxiety. But it goes beyond this. It also looks at domains like role functioning, which could be working, being able to work, social participation, and how you spend your leisure time, and are you able to do the things that you want to do. The second category, and what we call a core area of impact, has to do with death. And this is the So there we look at survival and mortality rates. So in every clinical trial, because this is mandatory, you have to look at, is there a reduced expectation of survival or mortality? And then finally, the third category of impact looks at resources. And this is not a mandatory core area, but it's optional. And here you have to think about healthcare utilization, direct and indirect costs. And here this is both from a societal perspective. So what are the economic implications of a particular intervention? But it could also be the costs and burden for individual patients who are affected by the condition and the intervention. And then there is a last category that are domains that we consider related to personal and the environmental context. These are contextual factors that do not have a direct impact on the outcomes of an intervention. But what we see in practice is sometimes that there are factors, personal factors or environmental factors, that do change the outcomes in a clinical trial. And here you have to think about domains like age, gender. So men may respond differently to an intervention than females. Disease duration, coping style. Some people have a more positive attitude towards interventions than others. And another example is adherence to treatment. So these could also, when relevant, and when there is data that indicate that these domains are important, then they could be added to a core set. So if we take this all together, these are the requirements for a core domain set. You have always one item, domain that's related to death, at least one item related to life impact, and one domain reflecting pathophysiologic. And then optional, there's a domain that is related to resource use. And you probably have noticed that we didn't talk about adverse events, but that is actually expected to be mandatory by law and also by the FDA and EMA and other regulators, that if you want market authorization for a new drug, you have to measure and monitor adverse events anyway. So therefore, we do not automatically include them in the core set, but we assume that they will be measured. The ideal core outcome set has between 7 and 9 domains in total, and the contextual factors can be added when there is data that show that it makes a difference to measure them. So now just giving a visual of how we develop these core domain set. This is the OMERACT approach for developing a core domain set. You first have to identify the domains of relevance. And if you end up with a long list of, let's say, 100 domains, you have to reduce that number by going through different steps and prioritize the ones that are most important and most characteristic for that condition. And then finally, you have to seek consensus among a wider group of stakeholders that agree that the procedure has gone well and the core set that is proposed has face validity and it makes sense to all the different stakeholders. Identifying domains follows different methods of research. You start with doing a systematic literature review, looking at all the articles that have already been published and what do they say, what is important. For many diseases, there's not much on the patient perspective, and that can make it necessary to do additional qualitative research, trying to get a better understanding of the needs and preferences of patients through qualitative methods. And focus groups is an often used method for this. And then finally, there is something that is called data mining, where you make use of larger databases of patients that are already active or participated in trials and other studies. So then you have a large number of domains. You have to start working on reducing the number of domains. And for this, we use often a kind of Delphi exercise. And the Delphi exercise has the advantage that you can involve a lot of stakeholders. It is done online, so people fill surveys in on the time that is appropriate for them within a particular time frame, and they are not influenced by the opinions of other people. So you have to prioritize and give your idea and preferences regarding a draft list of domains. And we do that in 2 or 3 different rounds. So for instance, if you start with 70 and all the domains that you find consensus for, meaning 70% indicate it as very important, then they go to the next round. And you continue the process till you end with an acceptable number of domains. And then you can have a kind of preliminary consensus meeting, could be face-to-face, but it could also be just the working group that agrees that this is the proposed draft core domain set. And if you have that, you bring that information to the OMERACT conference. It will be discussed in several small discussion groups, and people will look at different aspects and assess the data. Are they all convincing? Has nothing left out? And then on the last day of the conference, they will vote on the proposed domains. And if everybody agrees and there is 70% endorsement for the instrument, it is supposed to be accepted. So that's the way that a core domain set is developed. Always important to make sure that all stakeholders are involved in all the different steps, and that's a critical point. And for the Delphi exercise, our next webinar will specifically go into the details of how this works, why it is needed, and how patients can be involved in performing Delphi studies. So here I will stop and ask, are there any questions?
Martin, I just want to clarify, so the next webinar is going to be on the Delphi exercise?
Yes, that's right.
Oh, that's good to hear.
Yeah, and at the end we will show you the dates. I think they are planned for November.
Yep. Thank you, Martin.
Yeah. Any other question? No? Okay, and remember, if there are items maybe later on, don't hesitate to send an email to Shona on the email, the admin@omeract.org, and we will try to answer your questions or address any issue over the coming time. So there's always an opportunity to consult our PRP team. Pam, may I ask you to continue and introduce the role of patients in OMERACT?
Thank you. Thanks for that, Martin. So what are patient research partners? A number of you are patient research partners, so you'll be very familiar with this. But for those of you who have had very little experience or no experience as a patient research partner, we are people, all of us, with a relevant disease. So as I say, mine is rheumatoid arthritis. Somebody else had scleroderma. Whatever our condition is, we can be research partners. We just need a little bit of help maybe to begin with, a little bit of training if it's available, but we operate as active team members of the research teams. So we're not there as a research participant who fills in the forms, does that every week or 2 weeks for however many years. We are actually sitting on the research steering group. We're equal basis with the professional researchers in that we have a different type of knowledge. The researchers have learned knowledge and we have experiential knowledge. We have our lived daily experience, and that is what we bring to any phase and all phases of a research project. Why are we important? Well, we need to ensure that core outcome sets and core domains include the items which are important to patients, and those items are often aspects which are relevant to our quality of life, our health-related quality of life. Thank you, Martin. If we could go to the next slide. The next slide, please. Thanks. So we are there to make sure that all of those items are there, and not only are they there, but the whole facet of them is taken into account. So I'll give you a little example. The fatigue, when that was first raised as an issue, the research partner there pointed out that it was fatigue at all points, not just fatigue in flare. So the domain of fatigue had already been identified as patients, and then the patients was able to inform the researchers that it wasn't just fatigue in a flare, which they had started to assume and work on, but it was fatigue whether they were in a flare or not, whether their pain was under control. Fatigue just occurs at all times. In 2020, OMERACT is moving on to do virtual workshops. And this is a great opportunity to have even further input for patients to give their views and their voice about what's important. So initially there will just be 2 virtual workshops. As Martin has said before, very few patients can actually attend a conference. There are only 200 delegates at every OMERACT conference, and approximately 10% of which are patients. So you can imagine, for example, Tom says, has osteoarthritis of the knee. We can't have 100 people with osteoarthritis of the knee at a conference. So what we can do is we can all participate in virtual workshops instead. And that means that you have a greater impact on helping the research be focused more on what's important to the patients rather than just what's important to the researchers. So the 2 virtual workshops this coming April hopefully will increase the validity of those core domain sets. We'll have a lot more stakeholders. So for those of us as patients, we can't all attend a face-to-face OMERACT meeting, so we can join a shared decision-making virtual workshop, and that's open to any patient. Any patient can join those workshops online. There's also another one for flares and osteoarthritis. So obviously, if you have osteoarthritis and you experience flares, then those patients can also join that one online. So OMERACT is really looking to get as many people from all the stakeholder groups involved. So whether they're clinicians or patients or researchers, statisticians, they want as many people to participate online as possible. And you can also register your interest by emailing Shauna at OMERACT. So that's admin@omeract.org. The presentations will be available in real time, and also the voting will be available in real time, because voting at OMERACT is really important. So our role as patient research partners, we identify those outcomes. We help to select the instruments that measure, and sometimes we also help to develop the instruments that measure those outcomes if one isn't currently available or not entirely suitable. Our participation in OMERACT is different from some other conferences. It is not based on advocacy. It is purely based on informing informing research. It is not about advocacy at all, just about bringing our experience to research. So if we have a personal agenda, then don't bring it to the research. Take it more into the kind of advocacy role, because it's not helpful when you're trying to do collaborative research. If you happen to be attending an OMERACT biannual conference, then it is a very, very busy program. I have been, and I know the meeting starts at about 7:30 in the morning and they don't finish till 10 at night, which for those of us with health conditions is very grueling, because we're not only there to provide our input to our disease areas, but also the patient perspective as a person living with a health condition to all of the other areas as well. And that's the same, we are the same as every other delegate. Every delegate who's attended OMERACT attends every session. So unlike some of the big conferences where you can just go off for a couple of hours, unfortunately, when I've been to OMERACT, you can't do that. So it's very busy. So you have to be prepared if you ever are invited to OMERACT, know that that's going to be expected. Thank you, Martin. So things to consider when you're participating in a research team. Most of my participation is face-to-face with researchers particularly around Bristol, and quite often it's on conference calls around Bristol or the UK or the world. So that's sort of my daily, virtually, sort of daily stuff. It's in discussions, we have to be respectful of each other and be friendly. There are times when you need to make your point, because if you're in a room full of professors, then it's quite difficult to just keep quiet. But always, whenever you have something to say it in a friendly manner, not a sort of very pushy manner, because the aim is to agree. The aim is to come to consensus, and that's the focus, particularly of OMERACT, but also it should be the focus of all research. So think constructively and don't criticise anybody, because that doesn't really get people on side. Say what's obvious to you, because it may not be obvious to others. As I said, the person who looked at fatigue, she said something to her was obvious. She said fatigue happens all the time, but she nearly didn't say it because she assumed that the researchers knew that. But thankfully she did speak up. Have confidence to share your views, which are really important, and your views complement the perspective of other stakeholders in the group. Always maintain boundaries. As patient research partners, we are partners and colleagues in research. So we're there working with other colleagues on the team. we're not a patient who is being seen in clinic. You're only a patient in clinic. So, you know, you can't sort of go into a research meeting or a conference and then ask for somebody's opinion about your treatment, because that's only for clinic. And similarly, doctors shouldn't come to you and start trying to suggest how you could be treated better, because that's only for in clinic. If you work with your clinician as a team member, as I often have, then initially it can be a bit awkward, but you have to talk those things through and just treat each other as colleagues and not as patient clinician. Thank you, Martin. So be prepared. If you've got your first conference call, your first face-to-face meeting, before you attend that conference call or face-to-face meeting, write things down so you can focus on your questions when all the other things seem to just be clouding you. Especially for a conference call, it can be really odd when you first join your own, you know, your very first conference call. It'd be odd that you can't see these people and you're trying to listen to what they're saying. So write down your questions so that you don't forget them. Make sure you know what's expected of your participation and what you can expect from the team. Just ask. There should be a team member who may be your main contact as a PRP. So ask who would be your main contact, but you should be included in all emails, etc. If you haven't heard anything for a number of months or even a number of weeks, just email your main PLP and say, is there anything that's going on that you might have missed? So do be proactive. Be also realistic about your time. Researchers expect things to be done today, tomorrow, but for us it's not like that. It depends on how we are that day and how we are that week. So it's okay to say no, or okay to say I can do this, but it might take me another few days. So just let them know. And then do look at the spirit of OMERACT. The OMERACT website is very good for lots of information, and there's stuff from the patient group, but also OMERACT overall. Thank you.